guess what? Next week is the final, which is super exciting, which means you guys, most of you, are getting ready to graduate next quarter. You are going on to your last quarter. Isn't that awesome? It's kind of scary for you guys too, but exciting also. Sorry. Pause. So today we're going to finish up. We're going to do vascular and hematology. And because your final is on cardiac, vascular, and hematology, we are going to do our Kahoot, and then I'm going to do a little review. So that way should be ready, good to go. I figured by doing an oral one, it might help a little more. Never know. But let me talk about those pharmacology results. I'm pretty sure those are the highest scores I've ever had. Like I about fell out of my chair every time another score came in. It was amazing. Like you guys pulled it off. So, just so you know, before week 11, if you need a retake code for something, I can't do maternal and peds, because that's Miss Vest. But if you need mental health or fundamentals, send me the remediation and your grad date program. I'll get you the code and you can take it and level up. I'm sure all of you know how to use that by now. If not, I'll post the instructions for you. But this way, you can try to get up before next quarter, because next quarter you have right off the bat, you got community, your last quarter, for those of you going your last quarter, community, mental health, leadership, and comp predictor. And I have a group of them that just passed their comp predictor today. They're super excited. And I'd like that to be, you guys. I am definitely going to try to make sure I'm at y'all's pinning next quarter, because, I'd like to see all of you walk. I think it's very important. Some of you, I feel like I've known for a while, had you an intro, and things like that. So, yeah. Let's look at this week. So this week is your remediation. Make sure you get that in. Again, if you have a level 3, fantastic. Make sure, though, you put that report in the Dropbox so that I see it and I grade it. Okay. You don't have to worry about the live classroom if you're here. Obviously, if they're not here, sorry about your luck. And there is a practice dosage calculation quiz. You need to do that. You need to see where you're standing right now, because remember, next quarter, you go in, you're going to be taking one for, MDC4, and you got to be ready. So please, you need to do that dosage calculation practice quiz. Okay. Week 11, don't worry about the discussion. No need to do the discussion, because I'm going to go ahead and grade it, so I don't have to worry about it. Friday, after the other group does their exam, basically all of your grades will be finalized, because I'm going to have everything ready to go except just waiting on that final exam, since you don't have any assignments due. So make sure there's no assignments really this week that have to be graded. So everything will be, except for remediation. So please get that in. Everything will be done, set to go. Boom. Yeah, that's it. Final is on campus, 1:00. I'm gonna say it now, 1:00, so I don't get all the things mixed up. Same bat time, same bat channel. You know the routine. That's gonna be it. So, all right. Any questions about that before I get started? No, I don't know. Nope. You can type it, crayon, stamp it, carve it in stone. I don't care. You guys are quiet today. Ooh. Makes me nervous. Not really. Okay, well, we have, like I say, hematology and vascular. We're going to finish up today. And then we're going to do our little review. And yeah, that's about it. So have somebody that can't get in. Oh, I was like, I hope next quarter they go back to, but then I remembered I'm not teaching next quarter. Oh, I am. I'm going to be doing nursing care of the older adult. Is that Ninya? Also mentions that it's like dementia. Is that Ninya? Because I can hear her way over there. Did it? I'm sure. Anything had to do with children wipe you out. So, all right. So let's go ahead. We're going to start on hematology. We won't be. I'm not. We'll be done kind of early. So. I know. I know. Hey, I should last Proctor this quarter, right? Hopefully. One more little speed bump to get you to that dream, guys. One little speed bump. All right. All right. So, hematology, hematologic. Going to cover as much of this as possible. Plenty of time. So, all right. So, the first hematology problem we're going to talk about is sickle cell. A common problem amongst our African Americans. They say it can also be in some patients from the Mediterranean, Central and South America, but for the most part, it's African Americans. In the U.S., 7 to 13% of African Americans carry the gene. Girl, how does she always have problems with this? Anyway, we post it again. That's it's been every quarter. All right, so moving on. So signs and symptoms. So sickle cell, I want you to think about, now you'll have patients come in and you're like, oh my God, do they really have to act like they're in that much pain? These patients are in pain, okay? This is like having rubber bands on whatever area it's affecting. Some days it might be their legs, sometimes it might be their stomach, could be their arms, could even be chest pain, right? But whatever hurts, the blood cells are sickling, right? The red blood cells, the ones that are supposed to be carrying oxygen. So therefore, they're not carrying it the way they should be. So anything past that, you're welcome, Crystal. Anything beyond that, I can't think of the term, distal, okay, it's not getting blood supply, so it's painful. These patients, they'll have painful swelling, you know, they can have bone pain, again, because they're not getting proper oxygen to that area. I've seen, and many times this happens because of dehydration. I see a lot of sports players coming in with this, a lot of football players, especially working down there. And at St. Joe's, you had the baseball field right there. You got the stadium right there. You got the Yankees stadium. So I'd get a lot of athletes sometimes just overdoing it out there, getting dehydrated, and sends them into a sickle cell crisis. So, these guys also, because they're not carrying good oxygen and they're not perfusing well, they also carry a high chance for infection. These patients can get septic. They can get multiple organ dysfunction. So they need to get their, remember this, they need to get their immunizations like flu vaccines, Hep, Hep B, COVID, anything to keep them from getting sick. So the way they test this is called the sickle solubility test. It confirms the presence of the sickled hemoglobin in the peripheral blood. Sometimes they'll do a prenatal diagnosis to see also. So there's no cure. There's no specific treatment. The main thing is to keep hydrated. When the patients come in, they obviously need something for pain, but they definitely need oxygen and fluids, lots of oxygen and fluids. We want to do what we can to get them to help rebuild new red blood cells and to get the good ones flowing. And things like that. Folic acid regularly can help rebuild blood cells or build more red blood cells. But again, teaching them to stay hydrated. And please understand that these patients are legit when they come in pain. So first of all, if most men are pretty stoic about pain. Now, colds are a different story. I'm not even going to go there. No offense, guys, but the colds, you put you down for like 6 months. But pain wise, you're usually pretty stoic, especially African American male athletes. They're pretty tough. Football players come in, honey, they are curled up like babies because it's painful. It is like having rubber bands everywhere. So, try not to put it off that they're over exaggerated. First of all, most of the time they know it might be a hospital stay and they're going to get poked with needles and so they really don't, they wait and wait and wait before they come in. So try to have some empathy for them. Anemia, and meaning, low blood. So there's a lot of different ways that people can become anemic. It's either it's a reduction of red blood cells, hemoglobin or hematocrit. Here's your levels. You don't need to really know these for this test. So here is our first anemia, iron deficiency anemia. I know it's a hard one, but guess what? They are deficient in iron. Whoa. I know, it's crazy. Most common cause of anemia in children, adolescents, and pregnant women, especially young girls, because heavy periods. It can be from blood loss. Like older people, a lot of times it's from GI bleeds. You know, Women who are menstruating, if they have menorrhagia, heavy bleed, difficulty with their periods, they can have it. That's one way for ladies to get that ablation is if you keep talking about how you're feeling anemic and this and that, you don't want to have kids anymore and you don't want to have a hysterectomy, just go get an ablation. No more periods. It's fantastic. Iron-rich foods, women who are pregnant or menstruating, iron-rich foods are important. Everybody thinks, oh, you just got to eat spinach. It's not just spinach. They got grain breads that are iron rich fortified, beans, cereal, other things. So it's not just spinach, Also eat things that are high in folate, like spinach, lentils, and bananas. Take some folic acid because again, it helps to build some red blood cells. A lot of pregnant women have a hard time with iron supplements because it makes you constipated, and they're already constipated because the baby's sucking everything out of them and can't. Just wait till he gets older. So risk factors. So what can cause problems with red blood cells? Well, losing it for one. So, hemorrhaging, trauma, hemolysis damaging the red blood cells, sickle cell, sorry, immune disorders, So anything that can cause damage or loss of red blood cells can cause anemia. Bone marrow suppression, getting radiation, chemicals, that can cause it. Older adults may even become B12 deficient, uh, which is they have more nutrition deficient anemia, so like iron, B12, folate. And sometimes anemia can be misdiagnosed as depression or debilitation in older adults, because if you think about it, if you're low on red blood cells, you're low on oxygen. If you're low on oxygen, you're sluggish. You may have some confusion. You don't have energy. So that looks like a different problem than what it really is, Um, GI bleeding, again, common cause of anemia in older adults, can be from polyps, can be from ulcers, all kinds of stuff. So objective data, we'll see here we go. Subjective, a lot of times it'll be asymptomatic, but most of the time they'll be like, "God, just so tired," maybe a little pale, sensitivity to cold, you just feel cold all the time, um, irritable. And then all of these are because you're not getting oxygen, you know. Um, Patient may be tachycardic, um, nail bed deformities. For B12, they may have smooth, red, beefy tongue, right? And that is indicative of a B12 deficiency. It's like somebody who drank a big, gigantic red slushy or Slurpee, but it's swollen too. There's different iron studies. Uh, they'll draw total iron. They'll do the Schilling test for sickle cell. For B12, the sickle solubility for sickle cell. So B12 is called the Schilling test. B12, a lot of times they have problems with that from either having like stomach bypass surgery, because it's made with the intrinsic factor, right? And it's usually either because they're not taking in enough B12, or they don't have the capacity anymore to produce it. So they've had a gastrectomy, they've had gastric bypass. So that's when we have to do that. Your B12, those who have decreased B12, like, they are really tired all the time. So there's different medications you can get, the oral supplements. Um, you know, if you're going to give them parenteral, so IM, you're going to use the Z-Track method, and I heard they burn pretty bad. Again, the oral supplements, people hate taking them because they cause constipation. So you might have to, pump up your water some, or bulk up on your stool softeners, or Miralax or something like that. And they've got some over the counter now that says doesn't cause, less chance of constipation. So, or just do what you can. Obviously they want you to drink it with orange juice because vitamin C helps increase it. But also, like I said, try to do the foods. I love beans. I don't know about y'all. I grew up poor. I ate a lot of beans and rice, and I still love beans and rice. Um, and they're good for you. And if you just try to find some of the things that have all these extra stuff in it, you don't have to worry about taking the supplements unless you're severe. So, and then if you're severe, why are you? Let's fix the problem. So, let me know if I'm going too fast. Right? Oh, and let me tell you, I guess growing up poor, you learn how to, you, I am still really picky about some things, but like, I'll eat spaghetti and butter. I'll eat,
Yeah.
spaghetti. Go ahead, Amanda.
Oh, I was gonna say I'm the oldest of nine, and yeah, my parents had a lot of kids, and we always had like cheap food or whatever we could bulk up with. And, you know, on Fridays, it was like either we ordered Little Caesar's pizza or my dad threw together whatever was left over and made a soup.
Yes, yes, I had the same with us. I mean, you know, yeah, so Amy's the same way. I'm not picking like I won't eat mushrooms. I won't. There's some things I won't eat, but like I'll eat. They think I'm crazy in this house. I'll take a can of like bean and bacon soup and eat it with rice or with noodles. I mean, like I don't. As long as I have rice or noodles, I don't care what's with it. Really, you know. Make a sandwich out of just about anything, and I still love ramen noodles. You know, I don't care. I'll eat some ramen noodles, but yeah, I used to love cafeteria food. Like, so Carla doesn't like me eating too many beans, but you know, she could eat beans and she could eat beans every day. Carla loves beans and rice. Anything with beans and rice, she'll eat it. But so anyway, like here I'm talking about food again. You like them ramen too, don't you, Rashika? See, I'll throw some hot pepper. I'll put some jalapenos in there, some tomatoes, some hamburger meat, and some saute up, like thinly shred some cabbage and put it in there with those hot stuff. Like leftover taco day the next day, because we shred cabbage for our taco stuff like that. It's going in some ramen for me. It's like yes. Anyway, yeah, and it's cheap. Other people are like, that shit. It is gourmet ramen. Shoot, that's Ramon. That's some gourmet Ramon. That's not even ramen anymore. Costing a whole $1.50 for the whole thing. Um, even anyway, let me keep going. So, and oh, well, I like to brown up my hot dogs. I like cut them in little circles and then saute them in the hot dog pan and in the frying pan, make them all brown. I put those better cheddars
Grilled,
in there too. They good.
uh, I was going to say grilled or pickled.
What the hot dogs?
Hot dogs, yeah. Or
Oh, I like.
like the sausage.
Oh, I haven't had a pickle. Mm. Anyway, okay, so medications for this. So one of the good medications that it's good because it can actually help increase the red blood cells is erythropoietin, also known as Epogen or Procrit. The thing with this is you have to watch because if it starts building too many, then you can get fluid overload, right? So you have to watch for increases in blood pressure and things like that. Um, the bad part, I mean, that's one of the bad parts, but the other bad part is these patients have to go for an H&H twice a week, you know? I mean, so twice a week, that is like very important. B12 supplements, cyanocobalamin is B12. People get sublingual, things like that. The hard part with B12 is if you're taking it oral, the stomach acid, it doesn't even hardly get as much as you'd like it to. So most people will go for the IM method, because it's just, it's going to absorb it a little more. I just want to make sure it wasn't somebody can't get it. Okay, so that's anemia. Okay, now we're talking about leukemia. This is a cancer, and what happens with this is it's uncontrolled production of immature white blood cells. So in other words, they're not making the good white blood cells that fight off infection. They are making blast cells in the bone marrow. Okay, because of this, the bone marrow stops making normal production. Right, so they become anemic. They become thrombocytopenic and leukopenic. So thrombocytopenia. So thrombo clotting cell, right? So blood cell, your clotting factors, right? They become low on those. So guess what happens? These patients are going to start bleeding. Leukopenia, the leukocytes help fight off infection. So they're now not going to be able to fight off infection, right? Some different things that may lead to leukemia. viral infections, radiation, other different things. You know, some people just unfortunately get leukemia, you know. Here's what you need to know about leukemia. These patients can bleed, okay? Nosebleeds, bruising, petechiae, rectal bleeding, hematuria, um, you know, muscle weakness, fatigue, because remember, they're not only uh, losing their thrombocytes, they're losing their red blood cells. Oh, one's on my head.
No, but you said you had another
Oh,
pair. They said they can hear you, like really clearly. Hard for them to hear.
well, there's earbuds in over there.
I tried to put earbuds in.
Here, use this, and I'll use the earbuds. What, the earbuds that were sitting over there?
No,
Well, they might not be charged. Use those.
mine are charged, mine are fully charged,
No, you so
but
sassy.
they couldn't hear me. So,
You know if that works. If
thank you.
well, if it don't, then
Hi, everybody.
she's so sassy. Needy. If that don't work, let me know. I'll put in my earbuds. I can't hear myself talking. Sorry if I'm loud. Anyway, so they've lost their thrombocytes, so they're gonna be bleeding. They're losing their red blood cells, so they're gonna be anemic, right? Again, low on oxygen. And they're losing their leukocytes, so they're gonna be prone to infections. So they'll be feeling pretty rough, these patients. You know, again, blood clotting factors are usually abnormal. Fibrinogen, other factors are common. So, acute myelogenous leukemia, the AML, is the most common type. And again, you will see, you know, potential for infection, potential for bleeding. You know, so these patients are going to be on neutropenic precautions, right? So what does that involve? Remember, no flour, no raw vegetables, no raw fruit, not being around sick people. They're going to be on bleeding precautions, so soft toothbrushes, electric razors, things like that. So, and they may have to go on oxygen sometimes because they're low on O2. Surgery's not going to help this, you know. A lot of times they're trying to do stem cell transplants. They have a drug called Gleevec or imatinib mesylate. But infection is really a major cause of death with this patient. I knew this dude, he had leukemia so many times, but he'd get rid of it, he'd do good for years and then he'd come back and you know, but that's the thing. Anytime you have any kind of cancer or anything like that, you gotta worry about psychosocial preparation, so. Next is lymphoma. You have Hodgkin's and non-Hodgkin's. Hodgkin's has this Reed Sternberg cell and non doesn't. Doesn't really make too much of a difference, but this is a cancer that can affect any group. It appears in either teen and young adults or adults in their 50s and 60s. And I will tell you that lymphoma, it's very easy to cure, but if it's not found, it's very quick to kill. That's the bad thing. It's, you know, it's pretty quick, but so I knew someone, so one of the docs I worked with in the ER, Joe's, his daughter, she was at college, I think often at college, and she just hadn't been feeling good. He was talking to her on the phone and stuff, and she thought maybe she had the flu or something like that. She's like, yeah, I got some swollen lymph nodes. He's like, okay, you know, just keep an eye on it. So a few weeks go by and she finally comes to town and she comes to the ER and she's like, I just don't feel good. She said, and my lymph node is still really swollen. She had one like kind of like up in here. So they did a CAT scan. And it wasn't a lymph node. It was, well, she had lymphoma and she had like stage 4 lymphoma. And hold on. Can you not get it to work? Huh? Is it working? Is it working? Carla,
Yes.
it's working?
Yes.
Okay. Anyway, um, so within a few weeks, she was gone. She passed away. They couldn't, save her. And then like 6 months later, when the unit secretaries, her daughter comes in, early 20s, same thing. And passes away. So this is something that, if it gets caught early, very treatable, very, you know, but it's usually gonna be radiation. If it's a later stage, chemo, and hopefully, because you gotta think this is in the lymph system. And you know that the lymphs go everywhere, so. Multiple myeloma, I'm not even sure why we talk about this one. It's just a little blurb about it, but, it is a white blood cell cancer. Um, they are overgrown in the bone marrow, and then they produce excessive antibodies called gamma globulins. Basically, it spreads everywhere, very quickly. And treatment is chemo, but despite therapy, it's usually incurable. But most people they can do stem cell transplant, but most people don't even make it that, because it starts going, having pathologic bone fractures, goes straight to the kidneys, so it's pretty bad. That was it on that one. So I'm like, why even talk about it? Anyway. All right, so thrombocytopenia. Okay, again, um, you know, it is this one we're going to talk about is called idiopathic thrombocytopenia, purpura. So in other words, the platelets, right? They are making the platelets, but they're not around. Like, they're not able to find them. Either they're being destroyed, or they're just not making it through the body, right? So with this disorder, again, they have a low platelet count. Um, uh, they they start to bleed, and this is the one really that can go along with leukemia. So they can be on different drugs that can help suppress immune function, like corticosteroids, azathioprine, um, immunoglobulin, but aggressive therapy, it actually involves low doses of chemo. Now, since these platelets are messed up and uh, they don't have enough, they can do platelet transfusions if their platelets drop below 10,000. So, but again, bleeding precautions. Uh, this other one is thrombotic thrombocytopenic purpura. So with this, still making the platelets, but there's not enough in circulation, because these are just all going in one little area and clumping up, right? And then you got some that pass by, and then some that pass by and they'll go to another area and clump up. The problem is, where do they clump up, right? Could be in the heart, cause a myocardial infarction, could be in the brain, cause a stroke, could be in the kidney, cause a kidney failure. If this isn't fixed, it's fatal within 3 months, because again, they're not clotting normally. They have just clumps of these, just certain places, right? So they can bleed out and still clump up. Um, again, this is almost like an autoimmune disorder where the body's attacking itself. So what they can do is they will remove plasma, and some of the patient's blood, and then put in new plasma that can kind of help, they'll be on like a platelet aggregate, like aspirin, that might help. So, and again, immunosuppressive therapy. So a lot of these are like, again, the body's attacking itself and not wanting to do what it's supposed to do. Okay, you all right so far?
Yep.
Okay, cool. All right, hemophilia. Hereditary bleeding disorder. You hear this a lot with kids. Um, It's different from clotting, or from thrombocytopenia. This is from different clotting factor deficiencies. There's hemophilia A, which is our classic, and then there's hemophilia B, which is Christmas. Merry Christmas to you. With this, what happens is they just keep on bleeding. So like if, they scrape their knee, they keep bleeding and bleeding and bleeding. They cut their leg, bruising, they keep bleeding, bleeding, bleeding. Like Carla's mom has it. So one day she was shaving her legs and nicked it. My God, it was like a hemorrhage in the bathtub. I was like, but it is what it is, that you'll see I think it's named after somebody. I guess because if you don't get it fixed, you ain't making it till Christmas. Just teasing. I think it is named after somebody, but the last name is Christmas. I'll look it up in a minute. Somebody Google that and let us know. I'm pretty sure it's named after somebody though. I want the last name Christmas. So they'll draw PT and PTT. They will have a normal prothrombin time, but will have a prolonged PTT. Remember, PTT goes with heparin. You can put the two T's together and make an H. So like a H, like heparin. PT is Coumadin. Here is hemophilia. It's a rare genetic disorder, sometimes also called Christmas. Oh, see? So Stephen Christmas. There you go. Thank you, Stephen, for telling us about Stephen. Appreciate that. Stephen's my secretary. So, now here's what y'all need to know about hemophilia. They will complain about joint pain, joint swelling, right? Hips, knees, fingers, because with hemophilia, they get chronic bleeding into the joints, especially the hips and knees. So that is one of the main complaints. Angel, can you stop talking? You're just talking too much, please. All right. So the bleeding problems of hemophilia A, which is our classic, they manage it with regular infusions of like factor VIII. It's really, it's expensive. But Stephen, look up how much factor VIII replacement costs. They can get it from human serum, but you just have to watch because of any transfusion related infections. I think it's really expensive. Now, next one. This one's kind of a crazy one. We know that heparin is to help us not clot, right? So this one is heparin induced thrombocytopenia, right? So what happens here is it's an immunity again. Ooh, see, $4,100 per dose. They're like, man, I'm gonna get me some of that styptic powder for dogs. If I bleed, I'm just gonna put some of that on it. Just like some flour, it'll stop bleeding. Eventually, all bleeding stops eventually, right? So thank you, Steve. So with heparin-induced thrombocytopenia or HIT, it is an immune-mediated drug reaction. So what happens is, they have an unexplained drop in platelet count, right? But usually heparin keeps us from clotting, right? What happens here is it develops this crazy immune complex that activates platelets. And then these platelets neutralize the heparin, like they gang up on the heparin and like kick it to the curb and start increasing the thrombin and start forming, they can actually start forming more platelets. It's crazy, but at least you know that it's caused by heparin. It's just the body, again, reacting to the heparin and like going back on itself. So these patients can develop DVTs, but yeah, they call it HIT. So that's why when patients are on heparin, they really like to watch and keep getting their platelets drawn and things like that. polycythemia vera. So this is when you have too many red blood cells, okay? And this is actually like a cancer of the red blood cells with 3 hallmarks. They have a massive production of red blood cells, excessive leukocyte production, and excessive platelets. So like that blood is like, we talked about viscosity, so like this is like sucking the Chick-fil-A milkshake as opposed to the McDonald's milkshake. It is so thick. And you got to think too, if you have really thick viscous blood, your blood pressure is going to be high, right? They're going to be this dark purple kind of cyanotic appearance. They're going to have distended neck veins, intense itching because diluted blood vessels and poor perfusion. It moves so slow and thick that some areas they have stasis. They can get stasis ulcers. They can cause clot formation, um, have hypoxia. It's pretty bad. These patients, they're supposed to drink 3 liters of liquids a day. 3 liters. Avoid tight or constrictive clothing. Wear gloves when outdoors and temperatures lower than 50 because the blood's so thick and viscous, they're not getting good circulation anyway. Then add cold to it, they have to make their appointments, taking their anticoagulants because again, it's a buildup of platelets too. Elevate your feet so that you can get the blood returning back. Electric shaver, things like that. Don't floss between your teeth. Don't smoke. Everything's don't smoke. Treatment, get some aspirin. What they can do is apheresis, and in other words, withdrawing the whole blood and replacing it back with plasma to help try to rebuild the cells properly. Lots of hydration, anticoagulants. This is some thick stuff here, and it's not good to have that. All right. So let's talk about blood transfusions. Blood transfusions can be for a number of reasons. Could be just the patient's running low, could be because because they've had a hemorrhage and need just volume replacement. Thought I heard some. So pre-transfusion, very, very important. Number one, that the blood, if they're doing a type and cross or type and screen, that it is the correct patient's blood going to that lab. Okay. Need to verify the prescription. When the bag comes back, it usually has some papers attached, right? It's got the blood bag label on it, which has like the requisition slip, has the blood type on it, has the patient's account number, patient's, I think I said blood type, patient's date of birth, name, and all that stuff, right? And expiration date. So you're going to have another RN at the bedside, and you're going to be going back and forth, off the armband. Have patient account number, blah, blah, blah. Okay, matches. Patient's date of birth, yes. And it's very important that you look for anything weird with this blood. If you see any weird like gas bubbles or discoloration, cloudiness, just don't even give us. If there's any doubt, don't give it. If it looks like the label's been tampered with, don't give it. You got to make sure it matches. There's going to be the requisition slip that's on it, right? So they usually take that off of there. It's on it. And then they got to match the bag with this, right? With the slip. And they got to match the bag, the slip, and the name band, because you will kill somebody if you give them the wrong blood, right? You want to teach the patient to tell them, listen, if you start having any kind of chest pain, you need to let me know. If you have any kind of weird feeling, your tongue feels funny, you feel itchy, shortness of breath, severe headache, need to let me know. Okay, you're usually going to be there anyway, doing vital signs, pretty constant, but still. There's usually a protocol each hospitals, they're different, how fast they want it to run in. It always goes with normal saline. Okay. Watch for hyperkalemia, watch for fluid overload, you guys know what fluid overload looks like, JVD, swelling, things like that. Starting to hear crackles. Are they going into heart failure? Are they going into fluid overload? So these are things you need to find out, right? So they have all different kinds, red blood cells. You want to make sure you got to give a little combination. Like if you're giving tons of red blood cells but no platelets, they're not going to help. They're not going to be able to clot, right? They're not going to have any clotting factors, you know. Or they may do like red blood cells, and then they'll say every once in a while, let's go ahead and hang a bag of plasma, because that can help with the clotting factors. White blood cells can be transfusions. Sometimes they're given to neutropenic patients. I have never seen it done. So there's acute transfusion reactions, febrile, so they can have fever, hemolytic, circulatory overload, transfusion-associated graft versus host disease. I heard is horrific. So, all right. 27-year-old, history of sickle cell, comes to the ED with abdominal pain state that is rated a 9 on a scale of 0 to 10. Physical assessment shows she's grimacing and guarding her abdomen and has a fever of 103. Okay. Pale yellow, hard palate, several small ulcers on lower extremities. What's the priority problem that the nurse must immediately address?
Can I say it order?
Okay. It's A. It's acute pain.
It's A.
Yep, it
Oh,
is
I
A
was
for
gonna
this
say
one.
C.
Nope, it's A for this one because the pain is being caused by oxygen. It's because she's lacking the oxygen. And the more pain
Makes sense.
she's in, yep, more pain she's in, she'll probably start, hyperventilating some. That's going to blow off more oxygen. So here, we want to immediately address the pain because of potential for infection, we can worry about that. Potential for infection, it doesn't say she has any openings anywhere. She does have several small ulcers, but again, hyperthermia 103 is not too bad. I mean, decreased tissue perfusion. Well, that's over a matter of time. So right now, let's do the acute pain. So, okay. 30 minutes later, the patient's diagnosed with acute sickle cell crisis. She continues to have pain. Which drugs does the nurse anticipate would be prescribed for pain control at this time? Select all that apply. So we got meperidine, IV push PRN, Tylenol, hydromorphone, which is Dilaudid, morphine, IV push, or morphine orally or IM.
Morphine?
Morphine and hydromorphone, so C and D. So Dilaudid and morphine are probably going to be one or the two they pick. Demerol. So Demerol, they've kind of gotten away from. Demerol can actually kind of lower the seizure threshold. So they're trying to kind of get Demerol, man. Demerol and Phenergan back in the day, those were the shiznit. Like that is what you wanted if you were in pain. Demerol and Phenergan. But the Demerol lowers the pain threshold, and Phenergan started making people crazy. So, all right. 3 hours later, patient is admitted to the acute medical unit. Lab studies for the patient are ordered. What result does the nurse anticipate? Hematocrit 40%, sickle solubility 90%, White blood cell 7,000 or total bilirubin 0.5. Which of these is indicative to sickle cell? Right. Yep. B. All right. I don't even know what that is. All right. 4 days later, the patient is finally preparing for discharge. Which teaching point should the nurse provide to the patient and her family? A, be sure to get a flu shot annually. B, drink at least 3 to 4 liters of fluid a day. C, avoid extreme temperatures. D, alcohol can be consumed moderately. And E, engage in mild low pack exercise 3 times a week when not in crisis.
Can I answer?
Go ahead.
A, B, and E.
Yes. A, B, and E. Yep. Temperature extremes don't really, you know, what you kind of would be like, you would think maybe, but it's A, B, E. Very good. All right. 23-year-old African-American male with a history of sickle cell has an emergent open reduction and internal fixation of his right femur after a car crash. What is the initial post-op nursing priority? Sydney got it. B. Remember, one of the main causes, is dehydration. It is B. Okay. Because he's had he has a broken femur. So he may have lost a lot of blood. You can lose 3 liters a minute with that. You want to ensure adequate IV hydration. Very good. Come on, yeah. God's sakes. What is the priority nursing intervention in the care of an older patient with a history of diverticular disease and pernicious anemia? Preventing falls, monitor intake and output, turning the patient every 2 hours, or encouraging a diet high in B12. So pernicious anemia. Yep, very good. B12. Patient with polycythemia vera is admitted with reports of shortness of breath, hypertension, and loss of pulses in her right foot. Which of these is the priority nursing intervention? Assess current hydration status, administer oxygen by nasal cannula, elevate lower extremities on pillows, or evaluate the patient for hypertensive crisis. Student says A.
D. D.
Okay, I got a what? Did you say B?
D.
Oh, okay, I got D. It's actually, A. Because because it needs they need so much hydration status or hydration because everything is so thick, right? So they need that intravascular hydration. So you know, and then they're gonna need other stuff. So all right, that's hematology. Okay. All right, let's go take a few minutes. We'll come back at 2:10, and then we will do vascular. 2:10. Mm. Sorry, 1 second, guys. Anyway, all right. Try to put some here. See if I can find this one video I really liked, but can't find it. All right, so. Okay, so now we're going to talk about vascular. All right, so first we're going to start out with our peripheral vascular disorders, also called PVD. These can include um, uh, aneurysms, DVTs, varicose veins, Burgess disease, and Raynaud's. So first one we're going to talk about is peripheral arterial disease. And this results from atherosclerosis. So remember, athero, think of at for fat. Atherosclerosis is a thickening and a narrowing of the arteries because of buildup of fat. Also can be buildup of sugar, right? Arteriosclerosis is a hardening. So put these two together, an artery that, doesn't help with moving along the oxygenated blood, plus it's all gooped up. This is really bad chance, really big chance for decreasing blood flow. So when you have peripheral arterial disease, whatever that it's happening, you don't get oxygen there, right? So here you see that this foot is blue, okay? Because they have PAD of the lower extremities, okay? So it's blue. It's not getting oxygen, right? Let's see some. Okay, I just want to see some risk factors. Obviously, hypertension, hyperlipidemia, diabetes, sedentary lifestyle. Um, so they so the arteries like to be propped up. Okay, the arteries like to dangle, like the letter A, right? Arteries. So it feels better when they are in a dependent position. So if you ask the patient, do your legs feel better when you prop them up or when you dangle them? And if they say when you dangle them, it's an arterial problem. If they say they feel better when you prop them up, it's a venous problem, like the letter V, right? So because the problem with arterial is it's not getting oxygen. So if you put them in this position, the oxygen will get down to the feet and that will help, right? They also, with arterial, not venous, but they have something called intermittent claudication. And what that is when they're walking or exercising, which these people don't usually exercise much, they start getting a burning and cramping. And then once they sit down and just let their legs rest for a little bit in the dependent position, the pain goes away. They get up, they walk for a little while, it starts again. They rest, it goes away, right? A lot of times they can have burning and stuff in the bed when they're laying down because again, the legs aren't getting to dangle. so. They won't have a lot of hair down on their lower part of their leg because it's not getting oxygenated. It's not getting fed. It's not getting perfused, right? Decreased capillary refill in their toes, decreased pulses in their pedal area and their feet. May even hear a bury of the femoral and aortic arteries. So again, they're not getting good oxygen and good blood flow down there. Scale's gonna be, skin's gonna be dry and scaly, thick toenails. Man, things look like mulch pieces, like pieces of mulch. Dependent rubor, so they have like that reddening bluish, that they have, muscle atrophy, ulcers, so. So they will do an arteriography to see if there's any blood in it. You know, make sure it's flowing somewhat. And that's also going to see, is there a blockage? Is there a narrowing? Can't really see too much of an on an X-ray without some kind of contrast, right? So. You want to exercise to build up collateral circulation. Remember I told you how, older people start getting that because they've walked for years and they've done things right. Positioning instructions, do things where it's not going to impede blood flow. Don't cross the legs, reduce the legs, help to reduce swelling, but don't elevate them above the heart because it slows the arterial blood to them, but just elevate them some. Tell them to refrain from wearing really restrictive garments because again, you're not getting the blood flow down there. With venous, you want it restrictive down there because it pushes the venous flow back up. But if they have arterial problems, you want it to be able to get down. Hopefully that makes sense. You need a nice warm environment, some nice insulated socks. If they have decreased sensitivity, especially if they're diabetic, check that bath water, because you just don't know. And avoid exposure to cold because again, the blood flow is already slowed. So let's not slow it more. So try to avoid stress and caffeine. Try not to smoke, we know that. Vasoconstriction of vessels lasts up to 1 hour after smoking. They're going to be on antiplatelets, right? Because since they have this problem, we don't want anything else aggregating and causing constriction in those arteries. So some antiplatelets like clopidogrel, pentoxifylline, aspirin, antiplatelets like aspirin. Obviously might not be apparent for weeks, and to watch for signs of bleeding. You all know the signs of bleeding. May also be on some statins. If they need to, they can go in with a balloon and open it up to try to help maintain the patency of the vessel. How'd that word come from? Vessel. They can do angioplasty, which is the same as like they do for the heart. They go into balloon and they smush it off to the side. May have to put stents. Big thing is watching for bleeding at the puncture site. Check those peripheral pulses. Make sure they're getting blood flow down to the extremities. So arthrectomy, they can actually do, this is like a Roto-Rooter, where they go in, remove the plaque inside the artery with minimal damage to the vessel. You just have to be really careful because if they nick it, it can be really bad. Bypass, may do a fem-pop bypass, so they take femoral and bypass the popliteal or popliteal, however you want to say it. So a fem-pop bypass. Again, always check your color, temperature, sensation, capillary refill of the distal extremity, just to make sure everything is still is flowing the way it's supposed to be. We just said that, just said all those. Complications, if they have to have a graft, you know, you have to watch. Faculty driving that. If they do something to help open up the vessel, you have to watch for reocclusion, right? All of a sudden pedal pulses disappear. Someone says their foot all of a sudden hurts really bad, like something's closing it up, like there's a rubber band around my leg. Are they getting pale? Is it losing temperature? Is it getting really cold? Is it turning blue? You know, have to watch out. We may have to do an emergency thrombectomy in case they have a clot. So have to watch out for it. Compartment syndrome. So if there's all of a sudden all this swelling going on in a space, a confined body space, it can restrict blood flow and then result in ischemia, right? So anytime somebody complains of constant pain, especially like if they have dressings on or if they have a cast on, you know, then it can be causing all that pressure in there, and that pressure building up puts, again, pressure on the blood flow. So might have to do a fasciotomy, which is an opening into the tissues. And here you can see that they're building up that compartment syndrome in there after an injury, or a blood clot, could be a blood clot. And so everything is just there and piling up. So what they have to do is open up that fascia and let the pressure out pretty much, you know, so that, yes, if the fluid needs to come out, you know, and just kind of open it up. That's a fasciotomy. You have to make sure it stays clean, things like that. So PVDs, peripheral venous disorders. These are problems with the veins. With these, it's the blood not returning back up from the extremities, right? So arterial, the blood's not getting down. Venous, it's not coming back up, right? Can be from a DVT, could be from venous insufficiency, varicose veins, right? A DVT is a blood clot that formed as a result from light venous stasis. Somebody just sitting there all the time. Yeah, but I definitely have to get some TED hose for this new position since I'm gonna be home all the time. You know, and then this in turn can move around and become a PE. Varicose veins, again, you know, they're not helping with the blood flow coming back up. You know, it's like the blood goes down and then comes back up, right? So arterial blood goes down, becomes venous blood, because it's like a calf pump, they call it. If the calf pump isn't working correctly, then the blood can't come back up, so it needs help. Eventually, if the blood just sits down there in the bottom, it can start to cause venous stasis ulcers, right? Because it's just sitting there, it starts getting swollen. The superficial veins at the top of the surface, the blood has nowhere to go, so it's going to start seeping out and cause an ulcer. Eventually, may also cause cellulitis. And let me tell you, those venous stasis ulcers, they're kind of rough, you know. Some things to risk factors for DVT: hip surgery, total knee replacement, heart failure, immobility, anything, you know, that can keep the blood from coming back. So even like people like cashiers who stand in one spot all day, you know, if you just stand all day, you know, I imagine them guards outside of Buckingham Palace. I hope they take some aspirin or something, or they got some support hose under there, because they're just standing there in one spot. The blood's not able to move and come back up the way it's supposed to. Pregnancy and oral contraceptives, right? These can cause blood clots and those can cause PEs. So varicose veins, Did I show you guys the video of the really big pulmonary embolism? Not, I'm gonna have to show it to you. Yes, no, maybe.
No, I don't think so.
I'll look for it in a few. Varicose veins, be ready. That's all I can say. You're going to need, you don't need those fancy ass, fancy socks. Get you some soccer socks. They just as hard to put on as the others, and they're like $5, right? The other problem we're going to look at is an aneurysm. Aneurysms are scary and deadly. Basically, it's a dilation and a weakened section of the arteries layer. And it's usually caused by long-standing hypertension. And it's like a balloon that just keeps expanding. And most of the time, you'll see a AAA, which is the abdominal aorta. The bad thing is that they will complain of stuff like mid back pain, you know, just vague back pain. And then all of a sudden they feel like they have a ripping, shearing pain, right? So here it is here. And when this bursts, that's it. You're done. You know, basically, if that ruptures, pretty much all the blood in your body is going out. Okay. One of our docs in the ER called his wife. She was one of the AODs with me and said, "Hey, I think I have AAA." She's like, "Yeah, okay." I don't know if I told you all this story. I get lost on stories. But anyway, he came in, they did a CT scan. He went back to the room, started coding. They ran him to surgery. It had already ruptured, and he passed. These are nothing to mess around with. Some people have small ones and they'll just watch them for a while. But the thing is you can't just watch them. You have to do something about it. You want to watch this. If they do surgery, afterwards, you got to keep checking the pulses, because if the pulses start going away, where's the blood going? Okay, if they're getting mottled feet, if they have an NG tube in, it's to start to drain more. Watch the abdomen for increasing size. So with these aneurysms, you will hear a bruit and feel a thrill. So remember, bruit is blood gushing or trying to pass through somewhere quickly and kind of hard. And same with the thrill. So the patient might say, "I feel like a fluttering in my stomach, and it feels like something's ripping it in there." So they're scary. Oops. Again, listen for them. What are they saying? My patient that I had came in. She had she was just complaining of back pain. She was like a QD3. It was no big deal, kind of early in the day. Only history was being a little overweight, little high blood pressure. Said, "Yeah, I've just been having this achy back pain, and it's been really bad this morning though. And I just hadn't felt too good." And we're like, "All right, we'll get it checked out." So the doctor said she probably pulled something. Let's give her Flexeril. Gave her Flexeril. Went in about 30, 45 minutes later, and she just looked not so well. She looked a little pale. Her blood pressure that was in like 139/90 was now like 118/50. I was like, "You okay? How's your pain?" "Well, my back pain's gone, but I don't feel good. And my stomach feels like it's gonna rip open." And I was like, "Okay, I'll be right back." I went and got the doc, and I said, "I think this lady has a AAA." I explained to him what was going on. He's like, "Let's get an X-ray." Well, with X-ray, you'll see like a very widened mediastinum. So he's like, "She does have AAA." And he's like, "All right, it's called vascular." So we're trying to keep her calm, because the last thing you want to do is get their blood pressure up, right? So I'm putting IVs in and stuff. They send her to CT scan while she's there. Vascular comes, and her aneurysm goes from her mid abdomen all the way down into her iliac. It is massive. So he tells her, "I'm taking you to surgery." And she's like, "Am I going to die?" She looks at me and says, "Ronnie, am I going to die?" I'm like, listen, we're getting you to surgery. They're gonna do everything they can for you. And all I'm thinking in my head is like, there's a strong possibility, right? Get her in the elevator and she codes. Got her to the OR and it had already dissected and blown. So these are nothing to play around with. Like after that, every time somebody came in and said they had back pain, I was like, oh my God, it's a AAA, so gotta watch for hemorrhage. You gotta watch all that stuff. So, um, right. Especially if you feel like if you have back pain, then maybe you got a fluttering in your stomach. It's like, oh my God. Well, here's the thing is my ex, her dad was like the worst patient ever, drank, smoked, did all this, right, Joseph? He's always eating just crap. So he calls and he's like, I don't know what's going on with me, but I've been having this back pain and, mid back pain, and now my stomach's gonna hurt. And I say, you need to go to the ER like now. So go to the ER. He's got one. He's got a AAA and he's got new. Thank God it wasn't too big yet. And he's got one in each femoral, right? It's like, oh my God. So they fixed all them. Then a couple months later, he's like, can one of y'all take me? I got to go get my pacer changed out. Go there. He's got a thoracic aneurysm in his pulmonary artery. It's like, what the? He's like a walking clot, a walking aneurysm. So, but I was like, man, and still smoking, still drinking, but what you gonna do? So now we move to phlebitis, inflammation of the wall of the vein, usually because somebody's been digging with the IV. We won't talk about these others. Phlebothrombosis, DVT, make sure you don't have any symptoms. Could be red and warm, one leg's bigger than the other, or one arm's bigger than the other. The bad part is it can become a PE. And that's sudden severe chest pain. Like, I mean, sudden. I have had someone talking to me 1 minute and dead the next. These things are another thing that just make me nervous, but regular old phlebitis, warm soaks. If they do have a DVT, they can do a thrombectomy. Vena cava interruption, they call it IVC filter, inferior vena cava. They put that there so that if someone who does through a lot of DVTs, the blood clot can't go up into the lungs. It's like, why don't they do that anyway? Everybody should come out with that. Again, watch the vital signs, constantly checking those pulses. Ask about any recent injury, long bone fractures, more prone to put people down for a while, and they can have DVTs, any chest pain or dyspnea. Measure the leg and mark it to make sure it's not getting bigger. Nurse diagnosis. Varicose veins, they happen. They are also hereditary. People may have on the skin. Every nurse I ever know has had them. You can get them stripped. They can do sclerotherapy and stuff like that. If your legs become painful, again, if it's venous, if it feels better to prop up your legs, then it's venous. Leave them prop them up as much as you can. So. Buerger's disease. Buerger's is number one reason is smoking. Joseph, I'm screwed. So this one, it's like if they didn't name it after a person, I think they named it because it looks like hamburger, like burnt hamburger. But these are of the arteries and veins. The small ones lead to vascular obstruction. Patient needs to stop smoking. Sympathectomy, I don't even know what that is. Like, my mind is gone. So I know they said for Raynaud's, because I have Raynaud's, that sympathectomy probably wouldn't work. What is this sympathectomy? Oh, it's if they have a ganglion cyst. Y'all know what those are, those ganglion cysts that can happen? Anyway, so if it's caused by ganglion cyst putting pressure on the arteries, then they would remove it. So Raynaud's, again, they call this red, white, and blue, right? This is where, um, anytime the hands get cold, and like I said, I have this, you just all of a sudden lose all feeling and blood flow to your hands. It's very weird. They become cyanotic. The pain is pretty bad. And then especially as the circulation, it's almost like when your leg falls asleep, that really bad feeling when you got to try to bring it back. Yeah, so these are my hands. Anytime it's cold, more so cold inside, or if I'm holding a cold drink or something, I usually always have my drink in a cup, or I have like a napkin around it. Sometimes it takes a long time for it to come back to normal, and it is painful. The last episode I had it was the worst episode. Last Christmas, we went up to Georgia, and stayed in the mountains in the RV, and it was 20 degrees when we pulled in there. Okay. And and even though I had on gloves, I'm trying to hook up everything outside, and it went to where I couldn't feel my hands anymore. And they were throbbing and they burned so bad, and Carla had to take over. But I had to sit in front of the heater for a while and then put them under hot water. Heater, hot water, and that's why they tell people they have to wear gloves when they have this. I had on gloves, but it just got so bad and it was so cold that, but again, uh, avoid caffeine. Never gonna happen with me. I quit smoking, so they used to think this was all from smoking. Now they realize it's from repetitive hand movements, and a lot of times from putting pressure on these small arterioles and capillaries here, and therefore giving bad circulation in the arteries. And it's from people who sit on the computer a lot, okay, because you're putting pressure there. So watch for blanching. Again, encourage the use of MedSurg gloves. What teaching? Lotion regularly, your hands get really dry. All right, I'm going to show you all that video. It's crazy. Let me make sure I've got sound. Watching it. Let's see. This is crazy. So like, oops, oh no, got to put the sound on. Hopefully you can hear it.
Is a case of an acute pulmonary embolism from a deep vein thrombosis. Here we're performing a pulmonary thromboembolectomy using retrograde pulmonary vein perfusion. Here we've established the patient on cardiopulmonary bypass. A arterial line is placed in the right superior pulmonary vein as seen here. This is wide off of the arterial cannula and clamped. As you can see, the clamp is in place. We are on full cardiopulmonary bypass support. The next step is to apply the aortic cross clamp and achieve cardiac arrest. Here we're performing the pulmonary arteriotomy with a knife and then scissors, and you can already get a glimpse of the thrombus inside the main pulmonary artery as it branches. You can see a grasper is used to remove the thrombus. This is a very large saddle embolus that originated likely from the patient's femoral and iliac vein. She had a fracture of her right lower extremity, was in a cast, and this was a likely source from the right leg. You can see the embolus is removed. A Fogarty catheter is used to clear any further clots, which none are found.
No, that's not there.
Then at this point in time, we take the clamp off.
Wait a minute, this isn't the good one. Just give me a second. This is it. Yeah,
In this video, we're presenting a case of a
There we
massive
go.
pulmonary embolism and then a pulmonary embolectomy. The patient is a 30-year-old female who presented to our emergency room with back pain and shortness of breath. She had risk factors which included taking birth control pills and smoking a half a pack of cigarettes a day. A chest x-ray was obtained, and this was a relatively normal chest x-ray. Therefore, an ultrasound was ordered of her legs or lower extremities, and it showed a deep venous thrombosis or DVT in her common femoral vein. An echocardiogram was then performed, and it showed a large mobile mass on her tricuspid valve as seen here.
hey,
Following the echocardiogram, the patient became unresponsive and hypotensive. A STAT CT scan was performed, and you can see here at the saddle point on the pulmonary artery, there is a large pulmonary embolism. This prompted us to take the patient emergently to the
this is
operating
so
room
good. This is so
for a emergent pulmonary embolectomy and retrograde pulmonary perfusion. Here's the patient's heart prior to going on bypass, and you can see the right ventricle is distended and not functioning well because of the pulmonary embolism distally. In the right superior pulmonary vein, a arterial cannula was placed in preparation for retrograde pulmonary perfusion. The heart was stopped and the pulmonary artery was open. Here's the main pulmonary artery, and you can see a very large thrombus obstructing the main pulmonary artery at the branch point between the left and right main pulmonary artery. You can see how utterly large this pulmonary embolism is as we remove it from the pulmonary artery. It measured over 11 inches in size. On further inspection, there was even more embolic material. This is all thrombus that originated from the patient's lower extremities or her legs. She had a deep venous thrombosis, which then moved into her heart and caused this pulmonary embolism. You can see why DVTs can be life-threatening when they become pulmonary emboli. You can also see the clot extends into the small branch points in the pulmonary artery. This was removed as well. Here is the specimen that was removed from the patient's pulmonary artery. You can see it's almost a perfect cast of the patient's common femoral vein and iliac vein. And you can see this embolized or transferred from the leg to the heart and obstructed the pulmonary artery. Here we're performing a retrograde pulmonary perfusion to ensure that all the small clot and debris was removed. The patient was taken off a cardiopulmonary bypass and the heart was functioning well. She was extubated on postoperative day 3 and discharged home and made a full recovery.
Ooh-wee.
This ends the video.
Tell me that one, a good one. That is a good one. I need to copy that. Yeah, that just from a DVT. Man, it's like, good God. I need to put this in here. Sorry, just want to, before I forget. All right, anyway, that is a massive, it is, it's insane. I don't know. I think I had to remove the final because something happened to it. Well, you guys can do the Kahoot on your own. I'm gonna do a little review, okay? How about that? Okay, there you go. Somehow I removed myself on accident. Not somehow, I accidentally removed myself. Okay, so I'm gonna give you the oral review. I mean, you guys can. Yeah, I had to remove the final from Kahoot, just. I can't sorry about it. Anyway, all right, are you ready? Get your pens and pencils ready or whatever. Y'all can hear me, right?
Yeah, we can hear you.
Okay. All right, so your exam is going to be 75 questions. Okay. Um, again, on ground. After that, I'm going to talk to you for a minute about the ATI stuff, and then we'll be done. So, all right, here's what you need to know. I sent y'all the thing, right? What to do. You have your blueprint, but just I'm going to go over just a few things. You know, so. Okay, so what disorder? How do you think the blood pressure will be if a patient has AFib? Atrial fibrillation. How do you think their blood pressure will be? Yeah, low. It'll be low because they're not putting out well, right? It's more fibrillating. So I like how you switch that up there, Jenny. Um, always be therapeutic for that. What are some signs and main signs and symptoms or main complaints of hemophilia A? Very good. Joint pain. Yeah. Yep. Bruising, because you know they're bleeding. So um, fatigue. Yeah. So I'll type this in the chat box. Pancytopenia can be a side effect when treating lymphoma. Just need to know that.
How much did you cover?
What?
How much did you cover? I got disconnected for a minute.
Just hemophilia A, basically,
Okay.
just signs and symptoms. Patient has intermittent claudication. Remember, that's the walking, and then you have to sit down and wait, and then you walk and stuff. So if they have that, how will they feel better? What'll make them feel better? Rest. How should their legs be? There you go, dangly. All right. Oh, that's in there, but okay. Patient is having chest pain. Okay. What med? What are the meds you want to give for if they're having chest pain? Rule out heart attack. The four things you want to do. Mona, yes. Morphine, oxygen, nitro, aspirin. Nitro, you want to give that because, um, uh, you want to go ahead and open everything up so that they can start having better blood flow. You want to give the aspirin to keep them from getting more platelet aggregation. When you have oxygen, because they need it. Morphine for pain, right? So, let's see. A patient what might the patient be taking that would cause heparin-induced thrombocytopenia?
Heparin?
Yes. Very good. Anytime someone has a problem with bleeding, if like let's say their platelet counts are really low and stuff like that, what kind of precautions do we want to put them on?
Fall risk?
Fall risk. Yes. Bleeding precautions, yes. Fall risk. Because I mean, what's going to happen with those patients that fall? They hit their head, they bleed out. They're going to bleed into their head. So good job. Good job. Tell me what are signs and symptoms, both subjective and objective data for a heart attack? Chest pain, yeah.
Shoulder pain, arm pain.
Shoulder and arm pain, yep. Okay, what else besides pain? Troponin, yep. There you go.
Nausea.
Nausea, okay. Sweating, very good, Sydney, yeah. What about their EKG? Elevated ST, yes. Very good, yep. So EKG changes, positive troponin, sweating, nausea, jaw, back pain. CKMB, yes, but BNP is for heart failure. I mean, you can just to make sure they're not going into heart failure. So remember that this kind of pain isn't relieved with rest. For a true heart attack, it's not relieved. So, all right. Always see your patients with what kind of problems first?
Breathing.
Yep. Yep. Very good. What's the best way to prevent infection?
Hand washing.
There you go. Old school. So we know that okay, Jenny, we love you anyway. So we know that nitroglycerin can drop your blood pressure, right? Because it's a vasodilator. So what are you going to do if the patient all of a sudden feels really dizzy and feels like they're going to pass out? All right, have them lay down or sit down. What else?
I was going to say that, but it sounded way too obvious.
Remember, sometimes it's that easy. Let's say if it were a multiple choice, check the blood pressure. Very good. So lay them or sit them down, check the blood pressure, possible fluids. What do you always want to maintain? There you go, Brittany. Yep. Very good. Always watch for bleeding with any kind of cardiac surgeries, whether it's valve or anything like that. Watch for bleeding. Which cardiac problem are you going to hear the crescendo, decrescendo murmur? Remember I said, remember with this one, you're going to have that weird murmur. No, no, that it's not a rhythm. It's a problem with the heart. Okay. Let's see, mitral stenosis, aortic stenosis, aortic regurgitation. Yes, thank you. Thank you, Stephen. And Amy. Meh. There you go, Rashika. Well, Amy, you can't be perfect all the time, so. All right, next. Looking at cholesterol in labs. What kind of labs are you gonna see? How the cholesterol, how's it gonna be if they have atherosclerosis?
High cholesterol?
Okay, but which one?
LDL?
Very good. Yep, high LDL. Remember, L is the lazy, H is the happy. So high LDL, low HDL, right? It's just weird to know that any cholesterol is happy, but I like cholesterol. So peripheral artery disease, how are their pulses gonna be?
Uneven?
Yeah, they're gonna be low, like maybe, yeah, very weak. I couldn't think of the word. I always forget these words. Yeah, very low, very weak. Uh, remember, anytime somebody has polycythemia, like I was talking about earlier today, you know, uh, try to make sure they take their anticoagulants, because remember, with the polycythemia vera, they have too much everything, too many platelets, too many everything. So yes, hydrate, like 3 liters a day, remember? They need to hydrate. Can you imagine having that and kidney problems? Poor people. Let's see, diets for hypertension, uh, leukemia. Tell me some of the signs and symptoms you want to watch out for with leukemia.
Bruising?
Bruising. Yep. Fever. Okay. Yep. Anything bleeding, bone pain, because they could be bleeding into there. So, okay, good. Yes. Oh, oh, she's getting all fancy today. So, what is your first sign of digitoxicity? Right, Sydney? She getting all like, oh. First signs of digitoxicity. Yes. Good job, Brittany. Nausea, vomiting. And then blurry vision. It's a problem when you can't see to go vomit anymore. So, uh, you need to know the signs and symptoms of dilated cardiomyopathy. Anybody know those? Okay. Uh, maybe. So palpitations, tachycardia, yes. And you may hear an S3 and S4. So S3, S4, tachycardia, palpitations, fatigue. Yeah, it kind of mimics, remember those kind of mimic heart failure. Oh, sorry. Patient comes in with SVT, heart rate of 200 something beats a minute. What's the first thing you want them to do? Yes, Amy. Bear down. Good job, Daphne. Daphne hadn't said anything, but she's like, I know this one. Bear down. The Valsalva maneuver, right? Or vagal down. Try to do what you can. Good, good. So another thing with hemophilia, you will see a prolonged PTT like with heparin. So the PTT, it can form an H. So think of hemophilia and heparin. So what type of heart failure do you think has high cardiac output, fatigue, shortness of breath, and high fever caused by sepsis? What kind of heart failure do you think that is? It has high output. It has elevated output. Because remember, left-sided heart failure, you have low output. Right-sided heart failure, you have low output. What kind of output has high output? High output heart failure has high output. Remember, it was that one blurb on the thing that says high output heart failure is heart failure, but it has high output because they have sepsis. Hey, it may even say this patient has elevated, has elevated cardiac output. I'm just saying. You'll see it when you'll know what I mean when you see it, Joe. All right. An enlarged liver would be associated with what type of heart failure, left or right? Right.
Right?
Yep. Right-sided. So remember, righty-tighty. So everything gets enlarged, right? The stomach, the liver, the vessels. So yeah, good. Lefty lungy, righty-tighty. Sorry, Sydney. You can mess up once in a blue moon. Always watch for dysrhythmias. Patient teaching for heart failure. Give me some things.
If your weight goes up more than 2 pounds in a day, like you got to weigh yourself routinely every day.
Every day. Yep. Good. Decrease sodium. Good. Okay. That's right. Yeah. Teach about medications. Report symptoms. Yes, very good. Yeah, good job. Okay. People who have mechanical valve replacements, how long are they going to have to take anticoagulants?
Forever.
Yep. What type of patients should not take a prescription for propranolol? Yes, very good, Brittany. Ooh, look at y'all. Whoa. You may want to remember some stuff like metabolic acidosis. I don't know why that's on here. Um, so a patient has, hold on a second. A patient has a fever, they've got some night sweats, and they've got a new murmur. What do you think it could be? And they had dental work not too long ago.
Strep?
Oh, but what does that lead to cardiac wise? There you go, Stephen. Endocarditis. Yep. What do you do if you walk in somebody's room and there's no pulse? CPR. Good. Yep. So if someone is neutropenic, they have a problem fighting off infections, right? So always make sure you monitor, especially if the patient's not acting right, if they've got fevers or anything. Always look to see if there's any type of infection. That's the big thing with neutropenics. I just talked about that. You always worry about bleeding post-op. So anytime you'd have a patient that is bleeding after surgery, you worry about that. Signs and symptoms of anemia, severe anemia. Fatigue. Pallor, very good. Pallor, yep. Oxygen first. Good, Joseph. Yep. What can what other valve disorder can lead to left-sided heart failure? Try again. What type of valvular disorder can lead to left-sided heart failure? Try again, Brittany. Try again, Stephen. There's only 4 different kinds, really. Left-sided heart failure. Okay. There you go. Mitral regurgitation. Very good. Remember that safety first, right? Safety first. So if someone's taking a new kind of high blood pressure medication, what can happen to them? What can they have? Yep, hypotension, which could cause them to what? Oh, right. So somebody's taking some new or some new hypertensive meds. Make sure you just keep an eye on them. Always watch for bleeding if they're on blood thinners. Pericarditis. What is the big deadly thing we're worried about happening with pericarditis?
Fluid overload?
Sort of.
The lungs?
Close, Stephen, close. Has to do with cardiac, obviously, but. There you go, Brittany. Cardiac tamponade. Yes. Yeah, remember, and that's because the inflammation between in that pericardial sac is getting bigger and it's starting to almost drown the heart. So that's an emergency. Um, oops. Which electrolyte do we worry about when it comes to something like torsades?
Potassium?
Nope. Nope. Yes, magnesium. Sorry. I thought they had just put a new test in there, and all of a sudden I looked at it because I had to scroll down. I was like, okay, they have some every exam now. They're from here on out. They're going to put some things in their priority. Which patient would you see first? So we're always worried about any patients that may have problems with their airway. Remember that, right? Blood transfusions. The reactions usually occur within the first how many milliliters of the infusion? I don't know why I didn't go over that. It's 50. All right. How is the cardiac output when someone has valvular heart disease? All right. Any of those. Remember, they can lead to heart failure. So, all right. Thrombocytopenia. Okay. Now we know Amy's got those cytopenia fancy things. What are some things you want to avoid doing to a patient that has thrombocytopenia? So they can bleed out. So what are some things as a nurse you want to avoid doing? Invasive procedures, even simple ones like IM people, IM injections. How do women usually present with chest pain? Or even just having heart attacks?
Sometimes no symptoms.
Right. Yeah. Just atypical signs, right? Not really chest pain, not pressure, but yeah, maybe some nausea, vomiting, referred pain, jaw pain. Good. So I never discussed it, but another thing you might see with pericarditis is a new ST elevation, because remember with the pericarditis, if it starts squeezing in there, then the heart can't beat and it's going to cause a heart attack, right? So you might also see ST elevations with pericarditis. Okay. What might you see with a ruptured aortic aneurysm? Uh, yeah. But I mean, what might you see as it's starting to? Okay. As it's rupturing. Where's the blood
Pellet?
going? Well, where's the blood going? It's going into the abdomen. So watch for abdominal distension. Um, okay. So remember that with mitral valve stenosis, you may hear an apical diastolic murmur. Apical diastolic murmur with mitral valve stenosis. What's the best test to look at the heart as far as like failure, ejection fraction, and looking at all the chambers? What's the best diagnostic test? And you know that, don't look inside the heart. I'm putting you in timeout, Stephen. Yes, echo. Thank you. What do we want to look out for? What are some signs and symptoms of a blood transfusion reaction, especially the really serious one?
Shortness of breath.
Sort of. Next, what's the next one? What would be the next thing you worry about? No. This time it's not to do with
Flushing?
airway.
Is it flush?
No, it's chest pain. Chest pain. Chest pain. A sign of a blood transfusion we worry about, Joseph. Oh, Skylar, good. Yeah, chest pain. Yeah. So your patient's having a heart attack. There's no cath lab around, and you have to give the clot buster, the thrombolytics. What kind of patient do you not want to give it to?
Hemophiliac?
Yeah, anyone who bleeds, anyone who's had a brain bleed, anybody who has bleeding problems. Very good. Very good. All right. So, you know, the treatment for heart failure is what? Diuretics, digoxin, maybe blood pressure meds. What do you think the pharmacologic treatment is for dilated cardiomyopathy? Because
Something
dilated,
like atropine?
no, because dilated cardiomyopathy leads to heart failure. I just told you what the meds are for heart failure. So what are the meds for dilated cardiomyopathy? Diuretics and, okay, and digoxin, yes. Because you need something to help squeeze and you need something to get the fluid down, right? Good job, Joseph. Remember, you want to get rid of atherosclerosis or prevent it. You got to make sure you walk and you move, get up and exercise some. That one. What's something you can give a patient with sickle cell besides oxygen and pain meds that can help, help some? If their blood cells are sickling, what can you do? Okay. All right. All right. Besides fluids, what else could you give? Because their blood isn't that good.
Blood transfusion.
Oh, there you go. Yep, blood. All right. You have a patient in AFib and their rate is 180 beats a minute. What do you want to do?
Slow their heart down.
Slow their heart down. Very good. Yeah, give them some meds to slow it. Well, that one's not a bear down. Amy's new term, bear down. What's the main sign and symptom you will see with thrombocytopenic purpura? Purpura. Purpley rash. What is the device that can help with end-stage heart failure? Brittany. What is the device that can help with end-stage heart failure? There you go. Yeah. The LVAD, the ventricular assist device. That's that mesh kind of thing. There you go, Marilyn. That's common soon. What's a possible treatment for leukemia? There you go. Good job. I can give you all of these. All right. Make sure you know the nursing interventions for sickle cell. What will they do for a pericardial effusion? What is the procedure called that they'll do? Pericardial effusion. Order. Pericardiocentesis. They said this. Marfan syndrome patients are more prone to mitral valve prolapse. That is it, guys. That's all she wrote. Okay, so ATI. So here's the deal. If you want to retake an ATI exam, you need to, if it's for farm, which I don't know anybody in here, I mean, you all scored so high, but if it is for farm, just email me and say, tell me that you put your remediation in the remediation Dropbox. Give me your grad date and your program, and I'll send you the information. I'll send you the codes. You're going to have to test in the library, the LibCal. All right. If it is for another class, I cannot do peds or maternal. Okay. That's Miss Vest. If it is mental health, fundamentals, whatever, again, you have to send me the remediation. Okay, it needs to be new remediation, not the old crap you put in the box back then. And I need your grad date, your program you're in, and I need to know which retake it is. Is it the first retake? Is it your second retake? And then I'll get you the information. I'll put here in the announcements the LibCal sign up instructions in case y'all forgot. But that way, but that way, you want to try to get, you know, you want to try to get all your level 2s on the break if you can. I mean, you don't want to keep taking them if you're not ready, but you definitely want to try to get caught up because again, you don't want to go into the next quarter with all those ATIs to take. It's a lot. But I put those instructions in there now. Yeah. Thank you, Jenny. Yeah, so listen, good luck next quarter. I'm sure you're all gonna do well, but I'll see you next week anyway, before we say our goodbyes, but it has been a pleasure. I have faith that all of you are gonna do well. Just make sure you study hard. Because, again, this is 75 questions. And it's a doozy. Get your stuff in, because after noon of week 11, nothing. Well, I mean, there's 90 assignments to do anyway, but, just make sure, get ready for that final. Okay. Anybody have any questions? All right. We are done then. Done. You're very welcome. Very welcome. You guys will do good. Just one question at a time. And I will see you all next week. Thank you. You too. Appreciate you.